Canispera. I would try to make the lesson in Greek, but it's okay. So first of all, thanks, Chris, and for the kind invitation. It's an honor. It's a pleasure to be here to show something I've learned, and so I hope you can enjoy this. The problem is that I stayed 2 years working in Varese, but I spent a lot of time in Wien in the lab of Manfred Schabicher, and I think that I feel he is really my anatomical maestro. This is the nose. Cyrano, you know very well. There are a lot of corridors, and Paolo showed you perfectly the transpterygoid. There are tremendous possibilities passing through the nose and getting a lot of areas. But anyway, it's normal for every one of us. We are used to think the way simply because we know some way. So it's sometimes we need to change our mind. And so it is what I've learned, especially from Castelnuovo, not to be dogmatic. And because although we are really in front of a tremendous advantage. If you look at Christos, it's perfect. There are great surgeons. They are doing complex cases, tremendous surgery around, inside the skull base, the brain stem. So a lot of, but we are talking about transnasal. So we are just a little bit in a jail, and we are fixed boundaries. And so the amazing evolution, of course, but we are still talking about a transnasal approach. So the problem is that, and something can change in your mind, because this is my daughter, because a lot of, now she is 8, I don't think she was happy to, but Paolo, it's okay. I take this one. It's okay. There are a lot of skull-based pathology that are not amenable, and you cannot manage by a simple transnasal approach. It's not possible to get here or to manage this area or simply like this. So I don't want to propose the transorbital approach like the panacea for all your problems. It's a simple an opportunity. So I want to skip because I want to give you some message. But just to consider that expanding your field of view, you can find maybe some problems, but sometimes you can find some solution, of course. So where is the approach here? This is not, I'm not an inventor. This is a typical approach that plastic surgeons perform since a lot of years. And it is a very easy, trust me, it's a very easy approach. You have only to remember 2 anatomical landmarks that are staying below the orbicularis oculi muscle and not the levator palpebrae. Once you get this area, you can get the supralateral part of the orbital rim, and so you are in the safe place. So it seems to be, maybe, because this is not familiar for most of the ENT or neurosurgeons, but it seems to me that this is not a good reason for not trying, because I really feel that many of normal surgeons can approach this kind of pathology. So just a short summary. So the incision, you stay below the orbicularis and then get the lateral part of the orbital rim, and then you are in a safe place because the levator palpebrae muscle remain hidden by the periorbital bag. So where you can go? So if you understand the anatomy of the orbit, you can go in the anterior cranial fossa, but in the lateral part, and you can go here in the middle cranial fossa, in the lateral aspect of the middle cranial fossa, lateral to the gasserian ganglion and the cavernous sinus. So this what is the situation in Varese, here in Pisa. You can perform a multi-hands technique because the opening is not so small. I skip some cases, but I don't want to bother you with surgery. Just to fix the point, This is a post-op. This was a mistake. This was a fibrous dysplasia. The intra-op evaluation tell us malignancies. We stopped surgery. We left this part that we could remove as well without any problem. But the pathologist said us, okay, it's a malignant, and we decided we stopped surgery. This was a mistake. So this is the post-op. One of the great advantages of this approach in respect to the typical Pernesky approach of supraorbital is that the scar is well hidden when the patient has the eye open. So most of the time, no one can see the scar in the eyelid. Another case is a sphenoorbital meningioma. It's a very bad pathology. It's a complex cases. The anterior clinoid process is completely involved by pathology. It's very enlarged by the pathology, and I skipped surgery because it's boring. I show you only one minute after that. This is the post-op. This, I feel, is a very nice outcome. If you consider the neurosurgical aspect, consider the anterior clinoid, a very important structure, and the extradural or intradural. The anterior clinoidectomy is a very important part of many surgical procedures. And in this case, we performed a quite complete extradural anterior clinoidectomy simply by passing through a 2 centimeter incision of the eyelid. So without any temporal muscle management, without any intradural dissection. So the consideration is that we are ongoing, we are on progress, and as many people start doing this approach, as much more we learn from our mistakes, as I can show you, of course, after. This is another case. I would never go again to this case with a transorbital approach. This is an indication, is a mistake in the indication. It's not a problem of what you are able to do. This is wrong. You have not to go with this approach, okay? This is my mistake and of my colleague, because we decided to face with a big problem without the good instruments, but we did. The results was okay. I can tell you, okay, what nice results, it's okay, but I tell you, to be honest, that this is not the real and good approach for this patient. And not for the outcome of the patient. You don't see nothing. This was the first incision of the first surgeon that performed the biopsy. Our incision is that, as you can see, is quite hidden. You cannot see. So the patient was well. The patient is happy. But given the fact that you have to try to offer the best opportunity to your patient, I would not offer her again this kind of solution. So this is a case I operated in Spain last September with Castelnuovo. This is the first day post-op. I don't have any other post-op imaging because the patient is a Spanish one, but I know that as well. And this is a nice opportunity. This is a good case for the patient. But what I would like to tell you is that, okay, you have the lateral approach, you have a transorbital approach, you have the nose, you can combine. And maybe in the future we can combine even other approaches. And these are a perfect case in which you can express this concept. So what we are calling a multiportal means that you can use different doors to get an area, but with a different perspective. So you can face with different anatomy, different problem, and in this way you have a 360 degree vision of the lesions. And in this way, you can manage as well, maybe not 360 degrees, but it's a multi-parametric vision of the area of interest. This is a recurrence of sphenoorbital meningioma. No matter the way you decide to go there, frontotemporal craniotomy of thoughts or whatever, this is a very complex cases invading the parapharyngeal area, the lateral orbital compartment, the infratemporal fossa. And it is a recurrence. And these kind of pathology are very bad. You can really work not so easy with this kind of lesion. And of course, I choose for you the best picture. And so it is the story, but trust me, it is a good result. The patient is okay. You have no more important solution for this kind of patient. So this really is a good indication for a transorbital, a combined approach. Just to show you 1 second of the video, because I talk a lot and I don't show you nothing. The incision is, as I told you, on a crease on the superior eyelid. The dissection is performed below the level of the orbicularis muscle, and you get the lateral wall, the lateral part of the orbital rim. So you dissect the periorbit from the inner surface of the orbital content, the bony orbital skeleton, and then start drilling inside of the, this is a typical appearance of a sphenoorbital meningioma. It's an M-plaque meningioma. So you find very whitish tissue, no blood, it's dry drilling, and you find blood when you find the dura. The first landmark is to find the temporalis muscle. So as in any other surgery, there is a way you can go inside with a good order. So the first advice I can give you is to find the temporalis muscle, the inner surface of the temporalis muscle. You create your lateral border, and then you get posteriorly and superiorly. The dura of the middle fossa, it is the meningioma inside. It was the first time we opened the dura of the middle fossa. Now I have done 4 cases, but it was a case I did with Paolo here and Professor Castelnuovo. I was ill in that day, but we did a good job. This is the arachnoid here. It is the lateral wall of the cavernous sinus. Is a right side here, so it is the roof. It is the floor of the middle cranial fossa here. The patient was well. The endonasal time, it's absolute. This is the post-op. So it's the right eye. So you can understand how minimally invasive is the patient, is the approach, of course. This is a case, this is a very bad case, but tell me which kind of approach you can choose for the patient. It's a very young patient with a sphenoorbital meningioma and plaque running into the middle fossa. It is the most easy part, and inside of the conal part of the apex of the orbit. So I feel that we can discuss a lot about this case with the neurosurgeon, with the orbital surgeon. We decide, of course, to go. I feel that it could be an option in this case. The post-op of the patient, this is some picture inside, but it doesn't mean nothing. As you can see, most of the lesion inside of the orbital apex remains there, but tell me how can I do differently? In the first part of surgery, I perform a decompression of the optic canal in order to create space and push the orbital content medially. This is the resection. This is a fat. It is the resection of the bony part and the intracranial part of the meningioma here. So, of course, the problem remains here, and what we can do is what in literature is called functional oriented surgery. The patient remains still in the same situation. It is the first or the second day, so the movement of the eye is maintained. Most of the problem you see here now is disappeared because you put fat, but with time fat tends to shrink, so you obtain a good situation. I feel that these are not easy cases. So this is a solution. It is not the perfect solution for everything. I skipped this one. It is an extreme cases, but it doesn't add you anything. Okay. Just one word. I told you a lot about the superior eyelid, but the orbit can be used also through the inferior eyelid, just in that case in which combining inferior eyelid approach with a transnasal approach, also this case we did together in Varese 2-3 years ago, you can manage the lesion much better than with only one approach. And this is some technical part, you can create an incision of in the inferior eyelid is much more easy, and in that case, you can dissect the lesion and push down the lesion and take the lesion from the nose. Everything is fine? No, of course. As Paolo showed you, there are a lot of complications, and we are in front of this new story. And sometimes there is some bleeding, and so it's very easy to manage. But sometimes there are other situations in which you are really in a new position, and try to think to be in a bony lesion, start bleeding. I was with Castelnuovo, so it's a very skilled and experienced surgeon. We take 15 minutes to manage this kind of bleeding. Now I feel that I can manage in 1 minute, but the situation was that, like for ear surgery, drill on, and the dust will pack the lesion, and so everything was fine. As much as we drill inside, the bleeding was growing and increasing, and I edit the video, but trust me, 15 minutes in which the patients and the anesthesiologist say, look, you are losing a lot of blood. So at the end of the story, the new possibilities we have, like flow seal or any other hemostatic agents, is necessary and mandatory. So don't face this kind of surgery without all the possibilities that now are available, because it's your responsibility to be able to manage something like this. And if you are not able, and you have everything and you have done everything, okay. But if you know that with a flow seal you can manage, and you don't have flow seal, this is really an ethical problem according to me. So as you can see, with the use of flow seal, this bleeding was completely solved in a few minutes, in few seconds. Believe me, it's okay, something like this. We are not sure what this bleeding was coming from. We think that it was one of the feeder of the meningioma, maybe one of the temporal vessels. But anyway, it was a bad story. How to prevent the ophthalmos, I don't want to tell you. One consideration, the CSF leak in the nasal surgery is an important topic, and every one of us has experience in failure, especially me. And I tell you because I've done 2 times the same skull-base plastic in the same patient. In the orbit, this is quite not a problem, simply because the orbit acts like a support. So when you perform even a big dural resection, you can create a skull-base plastic with multi-layer, and in the fashion you have learned, and then the orbit, once you release the orbital content, push the content and the plastic on the defect, and then I've seen no CSF leak from the orbit. And I'm talking about of more than 1,000 orbital decompression for Graves' disease, in which we have sometimes a CSF leak, and at 4 big dural resection. So it is a very big difference. There is a very big difference between the nasal reconstruction and the orbital reconstruction. Just very few considerations. We are in the pre-scholar area. So we are trying to learn, and I hope that some one of you would try to enter in this new field, because I'm honest to tell you that we need to collect data, experiences, failures, and learn something from our experience. To tell something, we need to wait for at least a preschooler. We are a newborn, at least we need to go to the pre-scholar area or in the scholar area. But the topic and the concept I would like to give you is that try to consider the orbit a possible route to enter the skull base. So I understand this is an unfamiliar argument, but it's much more easy to learn this kind of surgery than to learn a typical extended transnasal approach. It's okay. For me, it's okay.
go on with the second
Yeah.
topic, and we can have questions at the end or comments.
No comments.
It's a different way of looking things, different approaches. I have never tried something like that, but I like your ideas and the way that...
I hope that someone will go on with this idea, because I do really feel that it can work. But what is important is that the impression is not related to one person. So it is necessary that any other person criticize your ideas and start thinking differently and, okay, make a summary and say, okay, it works or not. And so if I tell myself it works, it's not a good way. So it's, I would like to thank Christos for this topic, because it's impossible to think and to talk about the carotid in 15 minutes. And so some part I will skip, because I feel that you are tired and it is a very complex. I spend, trust me, more than 1,000 hours in this section, and what you see here is the summary of what I've learned in a lot of days spent in the lab of Manfred Schabicher, and it is not so easy. I understand it could be very boring to listen to someone discussing of anatomy, so I try to fix some points, and please forgive me for these lessons. I hope I will be clear as much as I can. So the carotid is everything in the nose, in the skull base. No matter the way you are looking at, the carotid is the queen structure of the skull base. So passing laterally, passing anteriorly, passing transorbitally, you have to face with the carotid when you extend your approach. Paolo has shown you some anatomical aspect that you have to fix in your mind in order to try to find this area, but as he admitted, and it is true, there is no way to know exactly the position of the carotid in the parapharyngeal way, in the parapharyngeal area. So the only things you can do theoretically is to find the carotid where the carotid is fixed, and the carotid is fixed in its bony canal, and the bony canal is in the skull base. So if you want to find the parapharyngeal carotid artery from an anatomical viewpoint without any risk to damage it, but I'm talking about anatomy, so it's not clinical application, is to find the carotid where it enters in the skull base. Two landmarks you have to keep in mind. The median nerve is for the medial aspect, and the eustachian tube with the musculotubal canal is for the lateral aspect of the carotid. This was my aim. I've read a lot of papers and books, and but you have to try to simplify to the essential every concept, because here, okay, you know where the carotids go, and it's perfect, but the problem is that there, as Paolo showed you, you don't know anything, and especially in the older people where you have the atherosclerotic process, you have a kinking, you have coiling, you can have a lot of these curves. So Schabicher is, I have no word to thank him enough, has taught me that there is only one anatomy and a different way to look at the anatomy. I hope you learn this concept. So I started to perform a lot of external dissection and then move endonasally. So the carotid is something like this. The carotid, the eustachian tube is something like this, and the median is there. So 2 points to fix this part, the median nerve and the eustachian tube. And you can find, and you can draw a lot of schematic like this one, the median, the eustachian tube, but you have to keep these two elements with you in these lessons. So the eustachian tube is here, and the carotid is there. This is the temporalis muscle tendon here, something like this. But no matter the way, I can show you thousands of slides, but the 2 points you have to keep with you is the median nerve and the eustachian tube there. Skip this one. just to show you that, of course, the relationship is still the same, but a different way you are looking at. So this iron part is inside of the eustachian tube. It is the petrous part of the carotid, is the vertical part of the petrous carotid artery, and the eustachian tube is indicating this angle between the vertical and horizontal part of the petrous carotid artery. So this picture, this is the window to get in the area that Paolo showed you, and I show you only this. I prepared for the Endo Milano just to demonstrate my idea to simplify all the concepts. So the eustachian tube, the posterior wall of the maxillary sinus, and the median nerve is there. And go on with the dissection. V2 comes to view. The pericarpal fossa is here. So the details, anatomical details you can find and you can learn in this section. Open the infratemporal fossa. The lateral pterygoid muscle comes into view, and the posterior wall of the maxillary sinus is removed as well. And this is the guardian. I like to call the pterygoid system the guardian of the parapharyngeal and infratemporal fossa system, the medial and the lateral pterygoid muscle, and the tensor veli palatini. And V3 is running just behind the pterygoid system. So it's a very logical approach. It's a step-by-step logical approach in which some elements remain and gives you some idea. And one of the concepts I like to stress is that try to keep your anatomy in the screen in the same way you are thinking it. I mean, what is above should be above. What is medial should be medial. What is lateral should be lateral. In this way, you are entering a new window every time, and you are oriented. Sometimes I saw surgeon working like this, and you see the orbit in that way, and it seems to be the skull base. So this is very confounding situation. The eustachian tube is indicating the carotid is there, and the median nerve is running to the anterior genu, or Casanova call it the medial genu, but I prefer to call anterior genu, and V3. So the relationship between the structure is still the same, the matter. So from an anterior to posterior point of view, V3 is anterior to the tube that is anterior to the carotid. So parapharyngeal one, petrous, and paraclival. The foramen lacerum is there, and the same. So V3 is coming from here. It is the region of the eustachian tube. It is the carotid. So if you are going from anterior, you find the V3, the medial meningeal artery, and the region where the eustachian tube goes to the bony part, the musculotubal canal, that covers the carotid canal. So I mean that it is the safe area because you are in the fixed landmarks in the skull base. These are slides you have seen. So mind the relationship is still the same. Few concepts. V3 and the eustachian tube. V3, eustachian tube. V3 and the eustachian tube. And coming endoscopically, V3 is anterior to the eustachian tube. The carotid, and the eustachian tube. As I show you many times, as Paolo tell you, when you are in the skull base, you have no problem in the risk of eating the carotid. Horizontal portion is eustachian tube that is running, indicating the musculotubal canal, like you can see here. Is an actual view of a CT scan, but it is the same concept repeated and repeated many, many times. So, okay, the problem is that. So be careful, like Wendy with Nicholson. The problem is that you can find a lot of landmarks when you are running in the skull base. I really feel safe when I am working at the skull base. When you are reaching this area, I feel that you should be really very wise, use a Doppler, try to think twice every time you are working in this area. I skip this one because I want to give some consideration about this concept. This is an exposure. Consider that all the slides are over the right side. Always try to be more clear. So the parapharyngeal part, it is the horizontal part, and it is the vertical part, it is the paraclival part. It is a part of a cavernous carotid. what I would like to stress is that there is a fisheye effect when you're working with a 2D endoscope. That means what? That means that this part, it is not easy for everyone of us to understand how deep is located. So the surgeon or a skilled surgeon can, using the endoscope in and out and touching, create in his mind a 3D vision of the structure. But the real problem is that if you base your ideas simply on what you are seeing on the screen, you do not understand and you do not realize how is posteriorly located the jugular foramen area. So it is much more posterior than lateral. It is one rule I learned in the anatomical lab. I was searching always for the jugular foramen area, and the first experience I did, and I didn't find, because I'm running too lateral, and the region of the jugular foramen, because the carotid is part of the jugular foramen area, is by far more posteriorly than laterally located. So keep in mind this concept because it could be useful here. So for the cavernous part, I would like to stress some concept. So this is part of the cavernous. We are calling paraclival, but neurosurgical literature don't use this kind of approach. The not endoscopic neurosurgical literature don't use the paraclival carotid. When you are approaching the carotid from a lateral viewpoint, this is a very short part. It is not interesting for them passing from lateral. It's a very more important when you are looking at the carotid from anterior, because you see the foramen lacerum, you have the median nerve. The median nerve for the neurosurgeon is nothing. For the traditional microneurosurgeon is nothing. And in this part, the carotid is running in the cavernous sinus, went down and go in this way. To be honest, this is not cavernous. It is called a clinoid. But just to simplify, we can consider all this part, the cavernous part of the carotid, and to be a little more clear, the paracellar area of the carotid. But if you look at the anatomy, this is not cavernous. It's a clinoid part of the cavernous sign of the carotid. So this is okay. This is the way the carotid do, the posterior band, the anterior band, and again enters with the dural rings. There are just small fascial system that close the carotid just like a collar, and then after that the carotid enters the intradural part. So this is the cavernous with the lateral wall nerves here, V2, the 6 that is not belonging to the lateral wall, 4, V1, and an endoscopic view. So the carotid is the right side, it is the posterior fossa here, carotid here, and the 6 cranial nerves here, and there are a lot of marvelous details. The problem, I am in love with the anatomy. This is the sympathetic fibers. And in some situations, you can also see sympathetic nerve. It is described in 30% of the cases. So it's a big nerve that can be confused with the abducens nerve. So this is the cavernous sinus. The 6th cranial nerve, it is one of the most important nerves because it's easy to be damaged, and the nerve is running from the pons, enter this area posteriorly. It is part of the cavernous sinus. It is called the sphenogulfa. It is a venous system. There, a lot of venous coming from the basilar plexus, the cavernous sinus, the inferior petrosal, the superior petrosal, as everyone goes there, just like in the sea. So a lot of rivers inside, and the nerves are passing through this, and there is a typical bend here. It is one of the points that the extreme neurosurgeon consider very important when doing a transcribal extended approach. I feel that this could be one of the last picture I show you, and trust me, if I'm not, it's not easy to be so clear in 50 minutes. It is the optic chiasm, so the pituitary gland, and it is the right paracellar carotid. So the relationship between the optic nerve and the ophthalmic artery is very, very important. Consider but that in 80% of the cases, the ophthalmic artery is not passing through the optic canal. It is passing through the superior orbital fissure. 8% of the cases, according to Lang, that is one of the most important anatomies of the last century. So this is important, but more or less 1 in 10 is different. So there are two windows, so the pituitary gland, an infrachiasmatic approach, the pituitary stalk and the dorsum cell, and the complex of the anterior communicating artery is here. So these are two approaches that Christos is experiencing in this kind of approach. These are two approaches that you can, not easily, but you can commonly do passing through a transplanum, transtuberculum approach. This is a very strange area. It's, okay. Have a look here. There is a tremendous venous arterial system that creates just like a ring around the stalk. And these arteries are very, very important because the superior hypophyseal arteries are arteries of the intradural part of the carotid. And this artery, if damaged during a transplanum or a surgery in this area, creates a big problem because they innervate and they feed the undersurface of the chiasm. So you have done a very nice surgery, you have removed the craniopharyngioma, you have done what you are best in your hands. You create a small damage in one of these vessels, and maybe you haven't seen these, and the patient wake up with a scotoma. So keep in mind this aspect. Okay, the branches of the ICA inside of the cavernous sinus are mainly two, and they are very important for the feeding of the nerves in the lateral wall. So the surgery in the lateral cavernous compartment can be risky for the nerves, not only for a direct approach, because the nerves are at least enclosed in the lateral wall, but simply because the infralateral trunk that comes from the lateral aspect of the cavernous carotid artery can be damaged, and if it is damaged, the nerves can suffer. Okay, so I think it's time to stop, and thank you so much for your kind attention.